Hey folks, Scott Weingart here, and this is an EMCrit one-to-one nursing podcast, and we'll get on with Candace in just a moment. I just wanted to thank you all for giving feedback, kind comments, constructive criticism. All of that is so welcome. We read anything you say. If you send it, we read it. I can't promise a response. Some of the things get responded to. Some of the things will actually be responded to in our question and answer episode, which will be episode 4, will be our first Q&A. We'll try to take a whole bunch of the questions and hit them rapid fire, but we read them all. Please keep them coming. People have asked, hey, do you want feedback on every single episode? Yeah, if you're willing to do it, we are so happy to get it. We just want to keep making this better. We want to sculpt it to serve your needs, to hit the things that you'd like us to address. And when you give that feedback, try to let us know what your level of experience is, because we're still trying to calibrate where to gear this show towards. Because really, in my heart, the mission is to take people at the beginning of their resus nursing career, their development, and bring them up to true expertise. And then some people have been at emergency nursing for a long time, but just have never been exposed to the experience and learning resources necessary to get them up to resus nursing mastery. And maybe we'll do a few shows geared towards experts as well, if there's a desire, a need for that. So let us know. All right. So today's topic is intubation. Yesterday, we did post-intubation. It makes sense, obviously, to do them completely out of order and do post-intubation and then intubation. It made sense to me at the time, but there's a lot of stuff in here. If we've missed anything, let us know. All right, let's get right into it. So, Candace, we're back. Another one-to-one nursing podcast. How you doing?
I'm great. Sounds like everybody likes our little work here.
Yeah, so far, so good. We'll see at what point we disappoint them, but for now, we're doing okay.
I'm not going to disappoint them. It's
right.
you.
No, I'm fully aware of the disappointment would come from my end. So,
of course, that's standard operating procedure.
All right. So we'll reveal to Candace the topic of today's episode, and it is intubation. We talked about the post-intubation last time. We might as well talk about intubation. And there's a lot of nursing-doctor interface on this one. So I'm curious to see what your perspective is, Candace. I have some very strong perspectives on this, and we'll see if any of them clash.
Oh, that would be great if they did.
Somehow on this one, I don't think they will, but we'll see. We'll see.
Maybe when we talk about whole bowel irrigation.
There you go. Yeah, that might do it. All right. So intubation is, often thought of as a doc thing, but what we worked for and what I think it should be is a real nurse-doc team-up, because if the docs are not bringing the nurses into the fold on this one, then patient outcomes, I think, are worse. And you're really losing the opportunity to have this enhanced awareness and capability of figuring out what's going on. And so what are your feelings in general on intubation?
I think that we need to be together to be able to do that. I don't think it's just a procedure for one. I think that I should be present when it's happening so that I can monitor the patient's vital signs, make sure you have the right meds, know what meds we're giving, the equipment. I think doing anything as a solo operation is a bad idea.
Yeah, absolutely. All right, so let's run through this step by step. And if I'm missing anything, Candace, you tell me that we should hit one we've missed. But let's talk about medications. And in general, the doc's going to be asking for something, whatever in the individual patient they think's right in that circumstance. And the nurses are going to be going and getting those meds from whatever machine your ED has. And before I came to our shop, nurses were asking, what dose of these meds do you want? And it was difficult because you never knew at the point you were preparing for intubation what you'd actually use. And oftentimes I'd want more, but you gave what you thought was an adequate amount of induction. The patient's still moving around and fully conscious, and now you have to get a second set of meds drawn up. It's a problem. So what we moved to is actually just full syringes of medication. And are you guys still doing that, Candace?
Yes.
Okay. This is a big change for most EDs. And so, for instance, you'd say, I want ketamine and rocuronium. And what you should be provided then is a 20 cc syringe full of ketamine 10 milligrams per ml. And so that's going to give you 200 milligrams of ketamine, and you should get 100 milligrams of rock. And on an average size patient, that's going to be adequate for both of those medications. If the patient's larger, then the docs should be asking for extra. And if the docs are not aware of this, then as a really skilled resus nurse, you look at the patient and they're 500 pounds, you might want to bring 2 syringes full of rocuronium, so 200 milligrams. And the ketamine, probably the 200 milligrams is still going to be enough. But what was your thought when we initiated this, Candace?
I was on board with making sure we used regular systematic approach. So every time would be the same, not the Candace and Scott way was one way and then the Dana and Matt way was another way. That's not okay for me. So I think that creates kind of the uniform system, right? And we all have the same approach. The 20 cc syringe and give you all of the ketamine in the vial. And not everybody is on board with that. Some still like to do 210 cc syringes. It's still there. It's still drawn up just in 2 different syringes. And part of that is because we don't always get it back, right? That drug has to be wasted, accounted for from a narcotics perspective. So that's the hesitancy I see. For me, I trusted that I gave you 20, you gave me back whatever was remaining, and we moved on. But certainly, I think other than that little variation, which you can see, all 200 milligrams of the ketamine is there. It's just broken into 2 syringes.
Yeah, I'd be fine with that. All right, so just to add emphasis to that, make sure we're all on the same page. What we think you should be doing is the doc should just be asking for the meds by name. I would like ketamine and rock. I would like etomidate and succinylcholine. And then you should be giving them full syringes full of those medications with the proper labeling, which we'll talk about in just a sec, but not asking, all right, well, how much ketamine do you want? How much rock do you want? First of all, because it's added friction and stress. Second of all, because they really can't answer that question at the stage it's being asked. So there should be a standardized process of how much goes into what kind of syringe, and then full syringes are handed to the docs, and then the docs could use it as needed. It brings us up to the next topic, which is labeling. And I see this done so badly in so many EDs. They will write in script on an orange label, and they'll fold it up over the syringe. So you really, even though technically it's labeled, it's not labeled in a way that's in any way helpful. And it's just labeled with the dose of the med in the syringe. And the problem with that is if you use any of that syringe, it's no longer accurate. So what we move to is, first of all, the international medication safety standards. These meds should be labeled with the name of the med in big enough letters that it's easy to read, with the, what do they call it, that safety script where if it's like epi and norepi, the nor is big.
Tall man lettering.
Tall man lettering. So we got all that, and then we labeled them in a milligram per ml labeling style, which means it's always accurate, right? If there's 2 cc's in that ketamine syringe, if there's 10 cc's, if it's a 200 milligram of ketamine in a 20 cc syringe, it's the same label for all of them, because the milligram per concentration, the concentration labeling is always going to remain the same. And that's how anesthesia does it, and that's how we started doing it. And then to avoid the script, we actually created label sheets, and we just made them on standard Staples labels that you would order after we started with the initial project, Candace. You would have those stocked. And that means the nurses just have to grab a label sheet and just pull them off. And then when you get to the higher levels of this, you have to put the label on in a way that it still allows you to see the ml gradations on the side of the syringe, because at the beginning, people were labeling in a way that you could no longer actually give 5 cc's of it. What do you feel about this labeling system? Are you guys still doing this? Have you evolved this? What's the deal?
So I have evolved it. It is now on clear labels so that you can't mess up the hash marks on the syringe. And I put a color-coded system. So typically when we do an intubation, right, we're going to use ketamine, rock, and push-dose epi. So the ketamine is green, the rock is red, and the push-dose epi is blue. So when I print it on the label, it's a full sheet of 10 of each one of those labels. And then you peel them off. And if we're going to use high dose ketamine, it's actually like a magenta pink. And it says high dose now on the bottom so that you don't mess up which label you're using in the event you're using a different concentration of ketamine. Due to shortages, sometimes you got what you got, right? So we need to be clear when we pass meds between providers. So that was the change that I've made. And then I still have a standard label with other meds that we use, like fentanyl and Sux and etomidate and all that kind of stuff.
And we'll put those labels in the show notes for this episode. Very cool. All right. And were those colors the anesthesia official colors? Because they actually have colors for all their types of meds. Wow. So that's super good. Maybe you could share that.
I'd like to use this brain occasionally.
No doubt.
Other than for my wittiness.
All right. Now, you had mentioned push dose epinephrine. And so are your nurses drawing that up for every intubation?
Yes, it is frequently asked, and it doesn't take long to do it. So we rather be prepared than not prepared. We went over that last week. If you got to prepare, then you're not prepared. So it's done at the same time when you pull the doses for the intubation meds, you pull that as well.
I love it.
I would love that it's pre-filled, and I attempted to get it pre-filled into the pharmacy, but I definitely met a lot of barriers because it does come pre-filled from the manufacturer in the exact same appearance as the cardiac arrest epi, like the Brister Jet, and there was much discussion about it being an opportunity for error. One, in the tech filling the Pyxis. Two, in the person picking the wrong one, right? So I still haven't been able to conquer that mission, but definitely something I'm working on.
Yeah, I think the win on that is if the pharmacy won't buy them pre-compounded, that they could just make 10 a day. It would take them like no time at all. And if they do that under the hood, then they actually could last 24 hours versus when we do them ad hoc, they're really supposed to be thrown out after an hour. And
I know. And I tell people that and they tell me that I'm crazy. And then I tell them to get a book and read it.
Yeah, to their point, they're right. Nothing magical destroys, but that's what the medication safety people are saying. So we're supposed to be following that. And you as an administrator obviously have other responsibilities besides just, it still works at 4 hours.
Yeah, it still works, Candace. Okay.
All right.
I don't want to have to explain that in another place.
Now, I have really pushed at the shops I'm at to move to rocuronium as the primary paralytic, and succinylcholine we just use occasionally in some rare circumstances. Is your shop still like that, Candace?
Yes, we use succinylcholine very little. Very little. It's actually in the Pyxis now. It's no longer in the refrigerator because we use it that little that the buckets in the refrigerator would sometimes overflow, and then it would, because there was so much in there and we weren't using it, that it would give us a problem. So I put it in the Pyxis.
Yeah, that's great to know. All right. So now we start talking about patient preparation. The docs are getting their stuff ready. And this is a real opportunity for a resus nurse to, and this is a fraught topic, Candace. And, but
just say it.
So if you get a good doc and a good nurse, then nothing's going to be a problem, right? And if you get a good doc and an inexperienced nurse or a nurse that's not great during the intubation, usually things will be okay. But if you get a bad doc, unless you have a good resus nurse, things could go horribly wrong. And oftentimes I've found, it's not always, but I've found that the bad docs are often the ones that are least likely to listen to advice. That's probably why they wound up as bad docs in the first place. So the resus nurses have to walk this very thin tightrope where they can suggest things for patient safety and good care, but they have to do it in a way that kind of sneaks under the barriers of the poor doc. So if they were about to intubate and you saw the patient's blood pressure was, 80/40, that's a bad circumstance, especially if they're going to be performing a rapid sequence intubation, taking away the patient's negative inspiratory pressure, and venous return goes down, things go to crap. So how would you politically broach that circumstance, Candace?
I don't think I do things politically correct, but I really foster an environment where nobody's comment should be disregarded, right? If you're bringing something forward, everybody should take the time to appreciate that, acknowledge it. So I think that's the way it should be universally. In this scenario, this does happen, right? And I think sometimes I go with more of the, hey, doc, I don't think you realize, but the blood pressure is borderline low. Do you want to consider giving something? Or did we really optimize the best way before we do an RSI here? Perhaps we could stop, regroup, optimize the patient before we proceed forward. And I think that you have to treat intubations that are not emergent, like patient has no airway and they will die. Like those are in one bucket, and then they're the majority of what we do. And I would say you need to treat those like any other procedure with a timeout. Everybody's on the same page. We've optimized everything that to the greatest ability. We have everything we need to be successful. If you start in the negative, you'll stay in the negative. But if you start on the positive, I feel like you'll continue on that trajectory.
Absolutely. From all the communication work I've done, one thing that usually sneaks by their defenses is just, hey, doc, I'm a little bit concerned about that blood pressure. Would you mind if we start some norepi before the intubation? And so you're not telling them what to do. You're just asking. You could even pull back a step further and say, hey, I'm not sure about this patient's blood pressure. Would starting norepi before we intubate help, right? And now you're putting yourself in a position where they're still, oh, yes, that's a great thing. And they're feeling like they're making the choice. This kind of personnel management, it shouldn't have to happen, but it does. And this is the mark of a good resus nurse is they're filling in the gaps for a doc that may not be doing exactly what they need to be doing.
Yeah, and I think it goes back to looking at the patient's global picture and anticipating what you will need, right? Because if you did need to get norepi, there's a high likelihood you're going to leave the room. And the last thing you want is for the procedure to start as a nurse after you've left the room and now you're missing something. So I think that really taking that time to do an essential timeout or a checklist and think about how the patient is right now and what our anticipated challenges will be during intubation and post-intubation, and be prepared for that before it happens.
Absolutely. Now let's talk about pre-oxygenation a little bit, because I want the nurses listening informed about what I think the best care currently should be. And then when they see it not happening, that might not be a circumstance to really intercede at that moment because it's a more departmental issue, but just for their own knowledge. So right now, most ED docs are preparing the patient for intubation just by putting on a non-rebreather at 15 liters per minute. And even 4 or 5 years ago, that would have been a bad call. It doesn't provide high fraction of inspired oxygen. It doesn't really denitrogenate the patient. But now, after a study published recently called Preoxy, and people could check out the podcast on that, I think most patients in the ED or critical care unit really should be getting some form of PEEP for their pre-oxygenation and for their apneic period. And the uptake on these things usually takes a few years, but that really is state of the art right now, I think. And Candace, have they started doing that at your place yet?
They do. They do. And I think as the more seasoned physicians push new things, that you will find that practice will become uniform. It's certainly on its way now.
All right. So that really means either a non-invasive machine, a ventilator, or there are ways, and I've published papers on this, to make it happen with a nasal cannula, a BVM, and a PEEP valve, and that would be okay too. But just leaving a patient on a non-rebreather for the full preparation of intubation really is suboptimal at this stage of the game. Let's talk positioning. Now, this is another one where the docs who are aware are doing it right, but a lot of them I see are not. And sometimes they're actively doing it wrong. Like they are taking the time to position the patient, and then they position a patient in a way that's really net negative. So the ideal positioning for a patient for intubation is that their external auditory meatus, their ear holes, are above the line of their sternum. So what you're really having to do on adults is put pads, blankets, sheets, something underneath their head to get their head high enough that those ear holes are above their sternum. And a lot of times docs will just intubate flat in the bed. Not great. Or what's worse, they'll actually pad under the shoulders. So you're putting the ear holes even further down below the sternum, and that's really not good. So that's the primary part of positioning. The secondary part is that their face is parallel to the ceiling in whatever position they're in. So if they're flat on the bed, it means their face is just facing up. But if they're head of the bed up a little bit, then you're really trying to crank their head back such that their face is close to parallel to the ceiling. So like the major plane of the face, right? So if you draw an imaginary line from their forehead to their chin, that's parallel to the ceiling. So that would be optimal. Now, if you see a patient, especially if they're a little bit heavier, they're not going to be anywhere near that position lying flat in bed. And what really needs to happen is you need about like sometimes 15, 20 sheets to get their head adequate.
And the hard sheets, not the stretchy sheets.
Yes.
You need the hard one.
Yes, absolutely. Or folded blankets, something. And if you see a patient whose ear holes are really far down from their sternum, that might be an impossible intubation. So this might be another situation where it's worth saying, hey, should I get some blankets or should I get some sheets to position this patient? Now, if they know and just forgot, this will really remind them. If they don't know, then it's going to be a tough conversation. And I don't know how things are going to go, but that's where the patient should be. One thing at your shop that we really worked hard at, Candace, is to get an intubation checklist that really empowers the nurses to say all this stuff, because now it's not coming from their direct will to try to intercede for patient safety. Instead, they're just doing what the department has said must happen in every intubation. So now all of a sudden that positioning is part of a checklist, that pre-oxygenation is part of a checklist. And so it really empowers the nurses. But even saying that, when we first started the checklists, the nurses were leery, because what we asked is, because we knew the docs wouldn't do it because they don't listen. We told the nurses, we want you to just read through this checklist, and then docs either have to say yes or check, or they have to fix whatever's missing. And the nurses were justifiably scared because they would have to now be telling them, and we're like, you don't need to know any of this. You don't need to, we'd like you to, but you don't need to. All you need to do is say it and then wait for them to say yes. Because ideally, if the docs know what they're doing, every item on that checklist would just be a yes. The whole thing takes 15 seconds because they should have already prepared all that. It only takes a while when they've forgotten something on the checklist. So what was your reception secretly when we first started checklisting, Candace, with the nurses doing the calling and the docs doing the responses?
I agree with you that there's a fear. Okay, that's 100%. I think they were afraid to say something wrong in that room. Like you're standing in front of everybody and there was that level of, if I did something wrong, could I be embarrassed? You could be like me and just not give a shit, whatever. It usually made for some kind of humor in the space when I did something that somebody didn't like. But I think that now we've made it like a standard that fear is gone. You just have to get over that hurdle. And we've made multiple ways to find the checklist, right? So there is a paper document that we use for kind of AQI process, I guess you could say, so that I could look at all of the components for the intubations I'm not present for. We've made little badge cards for the residents that come in so that when you're fresh, it's your July month like it is right now, we've already given those out. This is the expectation, right? You set that expectation. Same thing with the nursing staff, right? You're going to participate in an intubation. What are the top 3 things that you're going to do? And adding the checklist to one of those top 3 things is a must.
Hey folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
And they have to get over their own fears. And I think we've created that environment that everybody knows that's what you have to do. And then at the end, if they're like, I don't know what HOPS means, then we'll talk about that.
And we did an in-service for the nurses, and I think we recorded an in-service too. And that really makes it helpful because then they use it for the first time. They're like, I don't know what any of this means. And we're like, there's a video. We'll send it to you now. And then they can watch and they feel very secure in what each item is. The next thing is docs have a tendency to put their intubation equipment on the patient's chest. And just from a resus perspective, that's guaranteed all of that stuff's going to wind up on the floor. So if you see them doing it, then sneaking in a table and saying, here's a place you could put all your equipment might remind them that just it's Murphy's Law consistently. That stuff, when most needed, will be on the floor. And we have that on our checklist as well, that the equipment is on a table. Now, these Mayo stands are what just populate most ED resus rooms, and they're pretty useless, and they're prone to tipping. They're horrible. And you and I really had a fight to get those patient eating tables.
They're over the bed tables.
Over the bed tables, yes. To stock resus rooms with those, because those are big enough, long enough to do things like central lines, arterial lines, intubation equipment. But I don't see many EDs stocking these things in their resus rooms. Are they still getting stolen, Candace?
Yeah, I put the labels on them that said for procedural use only, so people would not steal them for a sandwich. But yeah, you do have to. There's always one behind the head of the bed that is where I keep the intubation box and the bag valve mask and stuff on there. Like a second one, if it's not, in addition to the one that's hanging already prepared for whatever may happen for the future on the oxygen. But the second one is the one that disappears. And the Mayo stand is just too small, right?
All right, let's talk suctions. There should be at least two. One inevitably is going to fail. And there's this latent error that is built into these are badly manufactured devices, because if the wall tubing is hooked to the center where it's supposed to be, then all is right in the world. But if the wall tubing is hooked to one of the peripheral suction ports, and then the actual suction line is hooked to the center, everything will work because there's no fluid in the system. You'll test it, you'll hear that beautiful suction sound. And the second you suction any liquid, it fills up that filter in the center and the suction stops working. So I'll put pictures of this so people can understand what I'm talking about. But I've seen it happen just countless times. And it's a real danger because everything is tested well. The suction sounds like it's working until you suction for the first time. And then immediately that first just cc of vomit is enough to just fail the system. I always, and I'd love resus nurses to be doing this as well, at the beginning of the intubation, check that the line coming from the wall suction pressure monitor is actually hooked to the center of the suction canister.
Oh, we got new ones now that
me.
have pictures on them.
Oh, that's great.
So on the top of the cover, it's blue, and it has a person with the whole adapter, and then it has the wall, like a picture of the walls, to put it in the right one. Remember we used to have those like white clearish ones with nothing on it and had 7 ports on the top, and you were like, which one do we put it in? This one now has photos on it.
That's great.
Engraved in the lid. That was a much better product.
Yeah, I think they're getting there. I think you still have the possibility of error if whoever was stocking that room was not a high level. So now, end-tidal CO2. The only way an ET tube should be confirmed is with waveform end-tidal CO2. And that's a big push in many centers. Their docs are still using the color change. Those are really problematic in patients with low flow states. They are inaccurate in patients in cardiac arrest. They're useless in patients who have vomit in their mouth. They will turn bright yellow from the pH strip, reading the acidity of the vomit, and give you the false feeling that the tube is in the right place. It has to be waveform end-tidal CO2, but I'll go a step further and say, if the docs are going to be reoxygenating with a BVM, those breaths should be monitored with end-tidal CO2. So ideally, there is end-tidal CO2 on the BVM before the intubation, not waiting there to be put on the ET tube once the patient's intubated. So you have your bag, you put the end-tidal adapter, and then the mask on. And all of a sudden now, when they are giving breaths during the intubation, they will be able to know if they're going in. But as a resus nurse, you should not, in your mind, feel the tube is confirmed until you yourself see an end-tidal waveform. If you don't see that, you should still be saying, is this tube actually in? Is this tube actually in? And it doesn't mean you necessarily verbalize it up front, but very soon in, you should say, hey, I need to see waveform end titles. You could even blame it on your documentation or what have you. But I've seen horrible things happen when the docs are telling me it's in with a colorimetric device.
Yeah, end title's just standard now. We use it for non-intubated patients, for intubated patients. It's an investment that's worth it in the end. It will tell you when there's a problem. It will tell you that your tube's in. It'll tell you that your tube's out, right? Even in somebody that you had intubated and walked away. I definitely think it's worth the investment. We do practice that way where we put the end title at the base of the BVM. But the BVM is prepared in the morning or after the last patient, I should say, but it's checked every morning to make sure the PEEP valve is on the end and the end title is hooked up. And it just sits there in the recess rooms. And then we keep end title tubing and adapters in a little bucket on the side in all of the non-resuscitation rooms in the event that they were full and we had no option but to use a standard room for intubation. I don't want you to have to leave. So there's end title modules and the ability to do that in every room.
And one thing that resus nurses could do, or you could watch the docs do it, but I like to blow to no prior to it. So without the adapter on, just the tubing, you blow into it and you should see a waveform, because if there's no waveform when you blow, either you're a vampire or something's wrong with the equipment. And what you'll see quite commonly is the docs will be in the esophagus, they'll put it on, they'll get no waveform, and then they'll say, oh, this thing must be broken. And that's the opposite of what you need to happen at that moment. So someone should blow on that at the beginning of each intubation. And it could be the resus nurse just checking. It could be the doc. But that's the only way you could feel confident that, yeah, the equipment's great. If there's no waveform, it's because the tube's in the wrong place. Let's talk about pushing meds. Now, we're both in New York. And in New York, the New York Nursing Association has said that nurses can't push ketamine, and I believe, is it propofol as well, for patients that aren't already intubated. Is that the case? Yeah.
Ketamine, propofol, etomidate.
Yeah. So that's a problem because you don't want the docs pushing the ketamine and then the nurse pushing the rocuronium. That's going to break the sequence. And as a result, in New York at least, but my feeling is everywhere, I like pushing my own meds when I'm intubating, because then I could decide exactly what I'm giving. I could decide the order of those medications. And so that's how I do it. But I have no problem with the nurses pushing the meds, but they have to learn how to do it right, which means that you have to, if they're doing a rapid sequence intubation, rapidly push your induction agent, immediately follow it with your paralytic agent, and then flush it. And I see a lot of stuff happening, like slow pushes of the induction agent, then a flush, and then slow pushing the paralytic agent, and then a flush. Or they push the induction agent and say, oh, so do you want the paralytic? And the doc's not even paying attention, and now the patient's fully induced, and they haven't been paralytic. Like, I see all sorts of these varieties. And this is very counter to what they teach in nursing school. Nursing school, in general, you never give anything by a rapid flush, and that's absolutely how it should be. You don't want to expose the bloodstream to large concentrations. You want to slowly, we're talking for regular things you're pushing, not even like slow push, but for regular things you're pushing, generally, what do you push it over, Candace? Like 10 seconds, 20 seconds?
Yeah.
But with the induction and paralytics, they really should be flushed in to get as minimal an apnea time as possible and to have that med take effect as quickly as possible. So if you're going to be the one pushing, sedative, paralytic, flush. Now, there is a school of thought that says you should push the paralytic, then the sedation agent, then the flush. We're not going to get into that here. If that's what your system's doing, it's not wrong, but it's an entire controversy that we're not going to engage. Testing the line before that is super helpful. You don't want to push those meds and realize that the IV is blown. What is the best way, Candace, that you test an IV line?
So I do a rapid flush and a pullback, right? I like to see the blood. That's how I test it, right? If you got to wiggle the IV around or tape it back, it's probably not the best one to use for induction. Just not safe.
Absolutely.
And then what are you going to do when all your meds are not where you want them to be? They're now all in the subcutaneous tissue.
Yep. Now, one of the moves we teach in resuscitation is if you're in this circumstance, the line was okay and it blew, maybe like it got pulled as they're positioning the patient or what have you, and you push the meds and it's obvious they're in that big medication wheel in the skin. And yeah, you could struggle to get another IV. And if the patient has great veins, maybe that's the way to go. But in most circumstances, when you need to get the patient intubated, that's why you're intubating them versus the semi-elective ones, just put in an IO. And oftentimes the docs might be a little bit cognitively challenged at that point because they were just ready to so suggesting that, hey, should we just put in an IO to get these intubation meds in, might be what they need as cueing. This is really, I think, the ideal role of a resus nurse during intubation is they're the ones who still have 360-degree awareness. The docs are task-focused. The docs are going to be in the midst of a procedure, while the resus nurse could still be aware. They could still look at the vital signs. They could know what's going on in the room. They could see that things are happening that the docs might be too hyper-focused to see. And so their brain, in general, should be more relaxed than the docs. So things like that suggestion of, hey, should we just place an IO and get the patient intubated and then we could get the line afterwards, might be something that the doc would ordinarily know but not think about in the moment. And you've gotten so far at your place to actually put the resus nurse behind the podium so that they really are separated from the ability to get task focused. And I think that when I first saw those, I'm like, this is ridiculous. We're not doing PowerPoint presentations. But then as I was with them for a while, I'm like, this is a brilliant idea because it really prevents whichever lead resus nurse is a part of that scenario from getting involved in troubleshooting the IV. They are pretty much forced behind that podium to have that 360-degree awareness.
I think they serve as the point of contact, and they do have that perspective where you could see everything and not be focused on your task, right? And really serve as the eyes of the proceduralist. And it protects them, right? So that people don't get in the way or ask them to do something. Like when I go into a room, everybody calls my name 800 times. But I certainly can do all those tasks, but you don't want me doing those tasks. You want me to be behind the podium, right? And that's the purpose of, and I don't let anybody put their stuff on my podium like they know better. Don't put your sterile gloves on my podium. You get yourself a bedside table.
I'll just briefly mention something called DSI, delayed sequence intubation, which is something that we created. And it's a slightly different way of handling this. And it would be pushing the ketamine and then doing something, waiting. It might be pre-oxygenation. It might be placing a NG tube. It might be seeing what the patient's hemodynamics are. And then after some set period of time, then pushing the paralytic. And so if the doc says, just push the ketamine, that's probably what they're doing. But again, in New York, that won't be happening. Or if it is happening, then you better keep it on the down low. All right. Video laryngoscopy should be used for every intubation in the emergency department. I could pretty confidently state that. And I know at your place that's the case in almost every circumstance, but I know many centers around the country and world that's not happened yet. So it's not something necessarily to intercede with, but certainly if they fail their first attempt, a good resus nurse saying, hey, do you want me to get the video laryngoscope, assuming it's not already in the room, is I think incredibly utile, but you don't want to leave the room. So when they say yes, you want to really assign someone, hey, grab me a video laryngoscope, because they should have been using it on the first try, but certainly by the second, it's, I think, obligatory.
Yeah, I don't know. We haven't used a direct in years, like years. Some of us that are more seasoned, I guess is the right word. We started our career with a direct model. So then we moved to video, and now it's just the standard of care. So maybe I'm spoiled in that aspect.
That's fantastic. And that's how it should be everywhere. All right, pulse ox. Now, this was a little bit of a fight with the nursing staff.
A little bit.
It wasn't that hard. The nurses, very understandably, if the patient started desaturating, would start reading off the sats at every single whole number between 90 and 70. And that's the exact moment you need to be fully task focused as the proceduralist. So what we came to as a compromise is that the resus nurse, who is the lead resus nurse behind the podium, should announce when the sat hits 90, and then when the sat hits 80, and then when the sat hits 70. And nothing in between those. And those were very useful. You want to hear the sat's 80. You should have gotten out from your intubation attempt at 90, but certainly 80 and 70 is a critical point where the patient now is at risk of succumbing to cardiac arrest. So those three are very important. In general, once the doc hears 90, they're doing stuff. So hearing 89 is a really not necessarily helpful at that moment when they should be fully task focused. You heard the scuttlebutt from the other side, Candace. How much pushback was there on this?
I think they just wanted acknowledgement of, I keep saying it's 89, it's 88, it's 87. I said, and what are you bringing to the table when you say that, other than a number that's decreasing by 1 or 2? I said, I can appreciate that you want to know that they heard you. I'm confident that they did, because the noise in the room should be at a safe level. I said, but it is super distracting knowing that every 30 seconds you're going to tell me a different number. I said, and if I'm really struggling, I think it just makes me struggle more because I'm now focused on, oh no, is she going to say something else? I think the SAT is at 90 and then SAT is at 80 and then SAT is at 70, which means we're done here, right? I rarely see SATs less than 80. And I would say that I'm pretty confident we go with it's 80, we need another plan, right? And that's usually well received, right? Because people don't really want to be that low. And 70, this is over, right? Like, I think that people can appreciate it once you start the conversation that way.
Absolutely. And you made a good point. The doc, when they hear the 98, 80, or 70, should close loop it. They should say, yep,
Yeah.
I hear 90% SAT. Now, let's be clear. The doc should not be continuing the intubation once they hit 90. In general, when the nurses are announcing 80 and 70, it's not because the doc's still intubating in an ideal circumstance. It's because they're actively rebagging the patient or trying to put an LMA in. But again, in those circumstances, they're very stressful. And so hearing multiple numbers, not as helpful as hearing those big ones. Oh, and you mentioned another important point that we'll just reiterate. Silent room is a safe room. Anytime a critical procedure is going on, there should be no noise. Just like, it's not even a low noise level, it should be no noise, which means getting rid of superfluous alarms, not having anyone come in with an EKG and try to get that looked at from a patient at triage while the doc's intubating, which has happened to me not infrequently. All right. So now, this is another one that's a little bit contentious, but I think we came to a good place, is calling anesthesia. And it only took one thing for a patient who had ARDS and was a rapid desaturator, and a nurse called anesthesia without even talking to me. And it led to a clusterfuck. It did not help. It made things far worse for me to really instill that what you should do, and we have this on our intubation sequencing, that's on our quality assurance sheet, is if there's been 2 failed attempts, the nurse should ask the doctors, do you want me to call anyone else? And the people that might be is a second attending or anesthesia. But in general, if an ED doc is failing an intubation and they're going to wait to anesthesia, that patient's at high risk of cardiac arrest. They should have already done other stuff. If they fail their 3rd attempt, they should place a supraglottic airway. And if that fails, they really should be performing a surgical airway, because even in a place where anesthesia is around, it takes them a while to get to the bedside. So anesthesia generally doesn't bring anything good to the table for a failed intubation. Now, where they're wonderful, and I think it's a mark of an excellent DDoc, is if you see a patient that could be difficult physiologically or anatomically, and you don't feel fully up to the task, then you should call anesthesia before you start the intubation. And then you two could work as a team or plan what you're going to do or do the patient awake or what have you. But calling anesthesia for a failed intubation is the mark of a failed airway system. And so please don't call anesthesia without talking to them. Suggesting it is a fantastic idea. There's some docs that really aren't up to the task. They shouldn't have been intubating in the first place. But don't do it without speaking to the doctors. And getting a second attending in the room, asking, should I call a second attending, could be immensely helpful. And a good doc, if they see a patient who's super complex, will just say, hey, would you mind being in the room so that there's 2 attendings in the room before they start? That would be the ideal. And if you see a patient that maybe you see a morbidly obese patient or a patient who has deformities or what have you, saying to the docs, hey, do you want a second attending for this one, is not a bad thing to suggest.
I think that goes back to the same global picture before you get started, right? You need to make that assessment. You need to be humble enough to say, I want another person here, or maybe I should call anesthesia, or whatever the case may be.
The last piece I have on my list is the debrief. Now, we formalized the debrief. In some places, it's informal. They'll just say, how'd that go? Anyone have any suggestions? But we actually have questions that feed into our quality assurance process. But it's nice because having that sheet really empowers the nurses to remind the docs that we have to do a debrief. And if something did go wrong, first of all, it goes on that debrief sheet and feeds back to our airway QA person. But in addition, it really gives people a chance to talk about it. Because oftentimes without that, nurses will have questions about what happened, why things went the way they went. Maybe it didn't look that optimal. And if they're left with that doubt of what took place, they might actually feel bad about it and go home and just have that feeling festering, or they'll talk to their colleagues and not really get an answer, which could have been provided simply by saying, hey, what do you think made that patient desaturate so quickly? You didn't grab an LMA. I heard that's what we're supposed to do for when the patient has a serious desaturation. And you could talk it out as a team. And oftentimes, unless the patient is still crashing after the intubation, we'll do that right after the intubation. Have people stop debriefing, Candace, or are they still doing it?
No, we're still doing it. We're still doing it pretty uniformly. And we use those sheets, just like you said, for QA purposes. One, because then we know that we're continuing to use the same approach every time, not a Candace and Scott approach versus a Dana and Matt approach. And it also gives us some information, right? Like, you'd be surprised at what people write on them. You find things rather than you're told things, which works for me as well, because I'm not there 24 hours a day. I'm there 12 hours, 5 days a week. And being there that time, great. I'm there. I know what's happening. But what's happening at 2 o'clock in the morning when I'm not there, I equally need to know if that's a problem, right? Same thing on the physician QA side. When they look at something, they're like, what happened here? It gives them the opportunity to take a look at that. And then when we know every intubation that occurred, so when we don't have a sheet, we also ask you why we don't have a sheet. Like, why didn't you do that? Was your shift like incredibly busy? You didn't get a chance? Why didn't the nurse do it for you? It's not you have to do that and I have to do this, but we have to do this.
Those forms don't go in the chart. So this can
No.
be a place where things are written and then they get destroyed. So they're not going to be discoverable. So this really gives a place to write what actually happened versus the chart where, yes, we're never going to lie. We're never going to write things that are untrue. We're never going to omit, but we also are going to phrase our language in a way that's really, I think, safe and protective versus the QA sheets are a place where things could be written to really explain the
Especially
complexity.
like noise. Sometimes I get a lot of that. Like, there was a lot of noise in the room, or I felt unheard, things like that. So I think it gives you that like informal closed loop, and it gives people an opportunity to feel like because they don't have to put their name on it. So I don't know who wrote it. And I'm not doing a handwriting analysis. So for me, it's, hey, why don't you tell me why this nurse said that this intubation didn't go so well? Did you have the same opinion? Do you think that we could have done something differently? We can only get better with the things that we know we need to work on.
Hey folks, this is Future Weingart quickly popping in. There's something I forgot to mention, and it is a particular pet peeve of mine. If you're going to be inquiring, and I know why you need to inquire, you need to put it down in the documentation in most places, the tube size, the tube depth, how much of the medication was actually administered. All of that is vital information, but the time to ask it is not immediately after the tube goes in, because that time really needs to be a full focus on confirmation that the tube is indeed in the right place and making sure the tube is properly secured. So the time to ask for all of that information is during the debrief, after everything's settled down. The patient's on the ventilator. We see waveform end tidal. The tube is secured. The patient's put back into a sitting up position. We've started the post-intubation sedation and analgesia. And now we're ready to debrief. And if for some reason we're not going to do a debrief, then that's the time. There should still be a 5-second debrief. And that 5-second debrief is, how deep was the tube? What size tube was it? How much medication did you give? That's the time for it. Not immediately once the tube goes in. That needs to be a task-focused period. And asking these questions, they seem innocuous. They seem benign. They create a medical error called a slip, in which you had something you knew you needed to do that's super important, but then someone says something to you, they show something to you, you look up, you put your attention to that, and then you come back and you've forgotten what you were doing. But what's worse is you've forgotten that you haven't done it, because your normal cueing mechanism in your head that leads you to say, all right, now I got to see waveform end tidal CO2. And like that was like so being put in the foremost part of your brain. Then you get a slip, you get distracted, you come back to it. That cueing mechanism is not there anymore. And you might just assume, since it's always natural, that you check end tidal CO2, and now nothing's saying, in klaxons and bright red lettering in your field of vision, check the tube. You might not check it. And things get missed that way. That's a lot of times how wires get lost in patients. It's not that the practitioner is an idiot and they forgot that they need to hold on to the wire. It's that they got distracted, had a slip, and then thought they had already taken the wire out. So those questions should be reserved for after. All right, let's get back in. Absolutely. Candace, is there anything we missed?
How about tube holders? There was a shortage of tube holders. We had to go to some non-conventional options, which I naturally vetoed immediately. One of them looked like a hair tie, like what I use to put my hair up in a bun. I was like, no. And I think that you need to, one, consider from a nurse, the patient's face, right? Skin, movement of the tube, pressure injuries, right? So tube holders, you need a good product. You need a safe product and you need a sturdy product. Again, it needs to be present at the time of the intubation, right? To have it there makes you successful the first time. I think that once something goes in, you don't want it to come out, right? And then obviously make sure that there's closed loop on your hemodynamic monitoring and post-intubation sedation, which we talked about last time.
Love it. And the commercial one we use at your shop and my shop is the Hollister ETAD. We don't take money from this company, but that's the best we found. It allows full access to the mouth in order to suction and see what's going on there for oral care. And it doesn't cause tube movement. So that's, I think, the one to get. All right, Candace, this has been another super fun episode. Thank you so much for your brilliance as always.
Oh, anytime. It's my pleasure.